pessoal, estamos aqui no SBU in situ, no CPU 24, e aqui ao meu lado o professor Gupta. O professor Gupta é diretor do serviço de uro-oncologia do MedStar Hospital de Georgetown University em Washington, D.C. E a primeira fala dele no congresso foi sobre prostatectomia sem biópsia. E eu vou perguntar para ele algumas coisas interessantes aqui sobre a prostatectomia sem biópsia, já que a gente sabe que não é o tratamento padrão. Professor, thank you for your attention, your time. Your first lecture in the Congress was about prostatectomia without biopsy. I'd like to know how do you select your patient? What criteria do you use? If you use another risk factors like age, genetic markers, things like that. Can you talk about a little?
Well, thank you for interviewing me here, and thank you to the organizing committee for inviting me to come to the meeting. It's an honor to be in Sao Paulo in Brazil. My first talk, as you mentioned, was about doing prostatectomy without doing biopsy, which I want to stress is not a standard of care. This is not standard in any guidelines or by any committees, but it is something that is an interesting idea, something that has been becoming more and more in the forefront for people because of the risks, the problems with prostate biopsy. It can be a very uncomfortable procedure. A lot of patients can have a lot of anxiety about it. In the United States, we do the procedure mostly under local anesthesia, so patients are awake. So obviously it's not a procedure they want to go through. It can also be costly. If somebody comes in with concerns for prostate cancer, as you know, very high PSA, MRI that looks abnormal, a lot of them want to begin treatment without waiting for the biopsy results to come back. So that is the idea behind it, but again, it's not a standard of care. The first paper that came out about it was by the Meisner group in Germany in the European Urology, and they looked at basically 20 to 30 men retrospectively, and they used patients with MRI findings that were concerning for prostate cancer, so PIRADS 4 or 5, and they also combined it with a PSMA. And a lot of that was based on something called the primary trial, which looked at use of MRI plus PSMA. They saw that if the PSMA had an SUV max of 12 or more, or if there was an MRI of PIRADS 4 or 5 plus an SUV max of 9 or more, that there was 100% specificity for prostate cancer. So that is one of the things that we look for now is can we use MRI plus PSMA along with clinical characteristics, PSA level, DRE, PSA density to predict if they have prostate cancer.
Nice. What do you think about the salvage prostatectomy in this scenario?
Well, the salvage prostatectomy, as far as I know, has not been studied in this scenario. Again, if you use a PSMA scan and there are signs that there is prostate cancer there and combine it with an MRI, in theory, it should be something that can be done. But again, as far as I know, it has not been studied in any cohort.
Very nice. My second question, last question, it's less technical question, but let's say my curiosity, how the American urologists, oncologists deal with this question, this theme, because you know that there's sometimes a legal or ethical problems.
Yes.
Because not a standard procedure.
Yes.
What do you think?
I think right now, certainly in the United States, the only way that this can be offered is through a clinical trial, where we tell them that, again, this is not a standard procedure, that it is, in theory, something that works, but ethically, legally, we can only do it as part of a trial. And then it takes a lot of counseling to patients, understanding that if they go through a prostatectomy without the biopsy, we are assuming that they have prostate cancer, but we cannot guarantee it without, obviously, the biopsy. I think the reason this is coming out more and more is we also do this in other parts of urology. A partial nephrectomy, a radical nephrectomy, we do without often biopsying the kidney. We do orchiectomies with testicular cancer without doing the biopsy. And same with adrenalectomies, we also take out based on just clinical characteristics, imaging, and so forth. So I think that's where the idea is coming. But I think we cannot do this at least without a clinical trial first, ethically and legally.
Very nice, Professor. I would like to say thank you again. Thanks a lot for your time, your kindness. I hope to see you soon in Brazil and Barretos. Thank you.
Obrigado.